Welcome to the ACMG Knowledge Nugget on newborn screening for Mucopolysaccharidosis Type 2 or MPS II. This activity is intended for educational purposes only. Neither I nor the Planning Committee have any disclosures. This session is approved for 0.25 CME. To obtain CMEs for this activity, you'll need to pass the quiz with a score of at least 80% and complete the evaluation. This session is a companion to the MPS II ACT Sheet, which is freely available at www.acmg.net/ACT. ACT sheets are intended to be immediate resources for providers who encounter positive newborn screening results. Please keep in mind that a newborn screening result is just the first step in the diagnostic process. Further testing and evaluations are needed to determine if the newborn has the disease, is a true positive result, or is unaffected, a false positive result. The ACT sheets are intended to provide an overview of the diseases identified by newborn screening and clear next steps for the management of a positive newborn screening result. This session will cover background information on MPS II, including clinical features and the underlying genetic cause, actions a primary care provider needs to take upon receiving a screen-positive test result for MPS II, clinical considerations, and supplemental resources. MPS II, also known as Hunter syndrome, is an X-linked lysosomal disorder caused by pathogenic variants found in the IDS gene. This leads to a decrease in iduronate 2-sulfatase or I2S enzyme activity. This change results in the accumulation of glycosaminoglycans or GAGs in the body's lysosomes. The accumulation of GAGs causes cellular dysfunction, leading to enlarged tissues and organs. The presentation of MPS II is clinically variable and is usually classified into two main types: the attenuated or non-neuronopathic type and the severe or neuronopathic type. However, it is important to note that there are overlapping symptoms between the two types, suggesting that the disease spectrum of MPS II is quite broad. After diagnosis, it may be difficult to predict the type of MPS II an individual will have. Individuals with MPS II are usually asymptomatic until about age 2 to 4, though some may initially present with an umbilical or inguinal hernia. A distinguishing and early feature of MPS II are hypopigmented papules and nodules. Later symptoms may include slowed growth, coarse facial features, decreased joint mobility, and abnormal bone growth with skeletal abnormalities. Individuals with severe MPS II often also exhibit developmental delays, CNS involvement, and a more rapid progression of the disorder. MPS II is inherited in an X-linked manner. The X-linked inheritance of MPS II means that biologic males are more severely and more commonly affected than biologic females. At this time, not all states provide newborn screening for MPS II. A good resource for checking a state's newborn screening panel is the newbornscreening.hrsa.gov website. In the states that do screen for MPS II, testing is mostly accomplished by examining levels of the iduronate 2-sulfatase or I2S enzyme, which is decreased in individuals with MPS II. Some programs also examine the level of GAGs as a second-tier test to help improve screening and rule out cases of pseudodeficiency. Pseudodeficiency is commonly seen in lysosomal disorders and is caused by certain known variants in the IDS gene. Pseudodeficiency means that a baby's I2S enzyme levels appear low upon testing, but this decreased activity does not cause disease. Babies with MPS II pseudodeficiency will have normal GAG levels. These infants do not have and will never develop MPS II. Now that you have an understanding of what MPS II is, let's talk about what to do if you have a patient screened positive for MPS II during newborn screening. You will need to take the following actions. First, contact the family and do the following. Inform them of the newborn screening result and that more testing is needed to determine if their child does or does not have the disease. Ascertain clinical status. No clinical signs are expected in the neonatal period, though some infants may have an umbilical or inguinal hernia. Provide the family with basic information about MPS II. Second, take a family history with a particular focus on the potential signs and symptoms in young male siblings. Third, arrange a referral to an MPS II specialist for genetic counseling, comprehensive clinical evaluation, and discussion of treatment options. The specialist could be a pediatric geneticist, neurologist, or transplant specialist. The clinical evaluations should include a comprehensive physical assessment by an experienced MPS II specialist. Fourth, working with the appropriate specialist, take steps to ensure biochemical and/or molecular confirmation of the newborn screening result. Confirmatory testing includes I2S enzyme analysis, GAG analysis, and IDS gene analysis. Fifth, report the final diagnostic outcome back to your state newborn screening program. Current treatment options for MPS II include hematopoietic stem cell transplantation and enzyme replacement therapy. As you continue to care for your patient with a positive newborn screen for MPS II, it is likely additional questions and concerns will come up. Here are some resources where you can obtain information on MPS II, appropriate laboratories and tests, and genetic specialists. Before we end today's session, let's have a quick review. First, MPS II is a serious condition, and identification of affected individuals is essential for administration of early treatment. Second, newborn screening may identify both the severe or neuronopathic as well as the attenuated or non-neuronopathic forms of MPS II. Third, ACT sheets are available on the ACMG website to review in the event of a screen positive result. In addition to MPS II, ACT sheets are available for many other conditions that can be identified through newborn screening.